myself introducing. It's my pleasure. Amos Mangan is here. And I believe that you are enjoying our regular session every Friday in this time. And our another brilliant colleague was with you before. So now all of you looking a very bright white area, and maybe somebody having the very darkness in front of you, and you are appearing the exam in very near future. And sometime when we prepare ourselves, if we ask each other, or I ask you, any of you, that delusion, and this is what could it be? Please, anyone can say, what could it be? This is a delusion, and this one. Could anyone feel free to answer my question? Raise your hand, please. The middle one. Yeah, Dr. Azad. What is this?
Yes, sir.
What is
Sir,
this?
small, sir.
Sir, this is
Sir,
delusion,
sir.
and what is this?
Sir, it's a illusion, I say.
Could be illusion. Okay. And the next one. What could it be?
Sir, it's a mixture of the pictures.
Anyway, when, the sensation of the topic you understood. If it is a delusion, it is illusion, and what could it be? Maybe hallucination.
Yes, sir.
So with which system actually we suffer, doctors suffer from delusion, illusion, hallucination to prepare for the exam? More likely to be nervous system. That is my idea. You may not agree with me, but it is a general sensation. So we have selected the topic which are actually a little vast for understanding, and we need to be more attentive and more mathematical. So today we will try our best to give you simple idea how to make the preparation for the PACES in the subject of nervous system will be easier. We will highlight today mainly the station, the clinical exam station, but even then, definitely it will be fruitful for all of the doctor colleague in any sphere of our practice. So with this few topic, we are going to neurology examination now. And for the examination purpose, we divide the examination of the lower limb, upper limb, cranial nerves, cerebral function, and some miscellaneous issues are there, which actually directly not related with this limb examination, cranial nerve examination, or cerebral function sometime. Very few occasions. So today, within these limited times, we will try our best to highlight and show. Before going to the nervous system topic, the main question in our clinical evaluation is, where is the lesion and what is the lesion? This is actually our topic. And if we say that what is the lesion first, actually what is the lesion means what are the pathogenetic process of the lesion? Could it be hereditary or congenital? And if it is acquired disease, many types of processes are ongoing, the nervous system disease, traumatic, infective, neoplastic, and others. And where is the lesion? For that, actually, we need to know how to examine the patient and analyzing all the findings. For that, we need to examine lower limb, upper limb, cranial nerves, almost all together, including other parts of the body, including the spine and other relevant examination. So if you proceed further, if you can see the screen now, the symptom evaluation can guide us with what is the pathogenic cause of the lesion about. Suppose all of you understood, I'm not being more sticky in this topic. Very, very sudden, usually vascular origin, the vascular disease, maybe sometime confusing with the functional disorder also. Almost every neurologic presentation, might be a differential of the functional disorder. So usually functionals are sudden onset, so there is fluctuation. And likely over time, over days and months, these are the etiology clue that the process underlying. And if we now try to identify what is the lesion, we need to know this neuroanatomy. Just to refresh all of you, my beloved colleagues, today, when we learn in our anatomy classes before, and I like to give some extra highlight on the touch sensation. I hope that it will be very, very useful and fantastic information for you. Suppose these are the pathways, the pain, touch, temperature. In general, pain and temperature, the first order neuron ends almost in the same level of the spinal cord. And the second order neuron passing towards the opposite side and going up. So by rule or by law, the second order neuron crosses the midline in the sensory pathway. And these modalities in the same level. But when the sensation of the dorsal column, the position vibration, including the fine touch, whether to say fine touch, they are passing up to nucleus gracilis and nucleus cuneatus in the same side and going up by the fasciculus gracilis and fasciculus cuneatus. Just be with me 1 minute, doctor. Possibly more, some of you know, but even then, I believe that some of you possibly don't know the difference between fine touch and another word is the light touch, another word is the crude touch. So for better understanding, I will take 1 or 2 minutes more time here. And and you have seen that we are examining the lower limb usually with a cotton wisp by the cotton, by touching the leg. And we are asking the patient, do you feel, do you feel, do you feel? Patient is telling that, yes, I feel. So we are telling that patient does not have any abnormality in the touch sensation. So may I ask you, anyone can give the answer by raising the hand. Actually, if we give the touch by the cotton wisp and asking the patient that, can you feel? Patient telling that, yes, I feel. Which touch actually we are examining now? Is it the fine touch or crude touch? Can anybody say, please? If you feel better to be interactive, it will be easier for me to give you more information also. Please, anyone can raise the hand. Nobody willing? Dr. Azad also there? Dr. Raihan Azad? Okay, so let me say my top. Yeah, Dr. Manirul. Thank you, Doctor. Please. You are given the mic and you can unmute by yourself now.
This is a fine touch, sir.
Fine touch. Fine touch. Yes. In general, our understanding is it is a fine touch. Can you differentiate the fine touch and the light touch, Doctor? Dr. Manirul.
When we check with the pins, then it is
Pain is the pain sensation, Doctor. It is not the touch. Pain by the pain, this is the pain sensation. So for that, I think those who are attending me now, most of you now confused and puzzled. And like you also, I was also puzzled, Doctor. The fine and the light seems to be the same words. But in understanding of nervous system examination of the sensory system, the fine touch, another name is discriminative or localizing touch. Just simply asking that, do you feel, this is a light touch or crude touch or non-discriminative or non-localizing. If I ask, where is the touch you felt, Mr. John or someone? If patient tell that, yes, I feel it in my lateral part of my leg. Dr. Manir, can you be connected with me? It's better, doctor. It will be helpful for me just to be connected and interact. Please, Dr. Manir, please, if you don't mind. Just as a volunteer. Yeah, you can unmute, I think, but please. But you answered very, very rightly as a traditional answer. So now from today onwards, and I'm confidently telling to you, doctor, that we are not asking where do you feel, we are asking only do you feel. Am I right, Dr. Maniro?
Yes, sir.
We are not asking where do you feel, in which part of the body. This is the localization of the pain. And this localization, actually, the sensation traversed by the dorsal column sensation. Okay, doctor? I am asking you, Dr. Manirul, but actually I am asking all of you, just getting your help as a responder. So, if we come to this picture, if the sensation coming by the second order neuron traversing towards the opposite side and going up, these are all fine touch. But the light touch, which is, sorry, I'm wrong. All are the light touch, opposite light touch. And the same side, fine or discriminative touch is the dorsal column sensation. So I think in future also you will be attentive to these modality of the sensation. Thank you, Dr. Manirul. And now come to the next one. Thank you, doctor. Don't feel shy, doctor, to talk to me, no problem. And in the lower limb examination, we find the sensory abnormality in this manner. And you know that this is usually in the paraplegic patient, the lower limb actually is deficient of sensation. Dr. Murad is here to tell something maybe. What about?
No, but just before we proceed to the next topic, you were talking about the fine and about the light touch.
Yeah.
So when you mention the dorsal column, does this mean that the dorsal column is responsible for proprioception, vibration,
yes,
and
yes.
the localized touch? You mean?
Yeah, localizing capability of the touch. This is the dorsal column sensation.
Okay, so when we put the cotton wool and we ask the patient, do you feel we are actually examining the crude touch?
Crude touch, yeah, doctor. Thank you for understanding.
And this is the spinothalamic.
Yes, spinothalamic. Very right. Very right.
Okay, is there then any, like sometimes they mention that the pinprick is more specific for the spinothalamic.
Very, very
is
right.
There such a
very
discrimination, or so we prefer the pinprick?
Yeah, for discrimination also we can use it, but by discrimination of the touch, we need to ask where is you feel pain or where is you feel touch also. If
But
patient cannot identify, identify, so we can think that patient has lost of localizing capability. Yes, Dr. Murad, please.
But this means that he lost his dorsal column function. It will not help me to test the spinothalamic.
Yeah, doctor. Yeah.
Okay, but still we don't use then the discrimination or the localization.
Yeah, usually we don't use because easily by the vibration and the position sense, we can get the idea of the dorsal column.
Oh, okay, thank you so much for this explanation.
Thank you, doctor. Welcome again. But in our clinical method, we don't need to examine all the modalities. This is the fact. But I just shared my very latest informations was confusing. And I told all of you that it was confusing me also before. Thank you. Okay, now we are going to that the previous one from where we came back. The sensation, the distribution of the sensory loss is very easy. Just in the central cord problem, Dr. You see, this is due to the syringomyelia. You understand that there are some central cord problem and causing this type of sensory loss. And these are peripheral neuropathy. So it's just repetition for all of you. If any critical message is here, I just, I will mention you. Now look at the motor pathway, just rumination or the recapitulation for all of you. from this motor cortex, everything is controlling towards, and the effector organ is the muscles of the gland. And it is crossing in the pyramidal level. Pyramidal decussation is there, going to the opposite side. So there are two order neuron mainly, upper motor neuron and the lower motor neuron. The cranial nerve also, it is though not popularly termed as upper motor, lower motor, actually almost the homologous of the upper motor, lower motor. So I will highlight to you with the picture later on with a very nice interactive manner to identify the area of the lesion, especially when we evaluate the case of the muscle weakness of the patient. Right. So we found the sensory, the control, the sensory pathway, as well as now the motor pathway with the upper motor and the lower motor lesion. Just to show you the connection, surface connection with the cranial nerves to the brainstem, very important area of the central nervous system. These are the pons, this is the medulla, this is the junction. In the junction, you have seen that this is a facial nerve 6, 7, 8, rather to say 6, 7, 8. In this junction between pons and medulla, and below this is that glossopharyngeal and the vagus, and down also more is accessory nerve. And beside there is a 12 cranial nerve. Above in the superior colliculus and inferior colliculus, third and fourth nerves are there. These are trigeminal nerve. Just to have a look, only to refresh the memory now. Again, refreshing you with the circle of Willis, and we come to the right side is anterior circulation and the posterior circulation. Very briefly, to differentiate the anterior and the posterior circulation, as a symptom, the vertigo is a very common symptom in the posterior circulation. Visual problem will be a common symptom for the posterior circulation stroke. And these are the carotid system. Okay. If we look at the surface of the brain's hemisphere, the distribution of the anterior, middle, and the posterior is as such by the carotid artery. And again, just to give you an impression of the here, I think all of you now you are remembering your anatomy life of your study. But I'm targeting to another issue to you now, that it's a homunculus, is upside down arrangement. Upside down arrangement is in the brain, the topmost area is involved, so patient will have the weakness in the lower limb, sensory as well as motor function. Anyway, so just a question is given to you by the picture. Now a quiz to you, who will feel better to respond the answer, to give the answer of the question. 80-year-old male presented with acute right-sided weakness. Examination revealed minimum right facial weakness, impaired elevation of the right shoulder with relatively preserved right hand strength. There was global weakness in the right leg, which appeared to be maximal in the foot. Which artery is most likely to have been affected, please? Can anyone try to give a quick answer by looking this picture? Yeah, Dr. Azad, please. Dr. Azad.
Sir, it should be anterior cerebral artery lesion, sir.
Anterior cerebral artery.
It affects more on the lower limb than the upper limbs.
Very right. Very right. Thank you very much, doctor. It's very simple though, just to refresh and to be confident. So during the examination if we are allowed to examine the upper limb and lower limb, and it happens usually in the stroke patient, we may have an idea which artery is mostly involved. This is just simple example given to you. I hope, though may not be true, that you don't have any question in very small topic we discussed. I think we can proceed now, and if you have the query, you can raise your hand in between our talk. Now come to the main issue of examination of lower limb in the perspective of the neurologic examination. I like to show you now the parallelly, just to make a homology, that examination of the upper limb and the lower limb, we're getting the basic ideas, the screening purpose, tone of the upper limb and lower limb, the power, reflexes, coordination, and the sensation. So these are the headlines we have given to you just to make our understanding easy, that in the concept of screening means upper limb screening is the pronator drift with the arms outstretched, and the lower limb is the movement of the limb by gait. We tell that can you walk for me? You know this the professional mannerism, how to talk to the patient. So this is the way, and upper motor, lower motor, in the cerebellar functions also there, especially the coordination in the upper limb as such. These are the maneuver, and the lower limb, these are the things, heel shin and the broad-based gait, slow gait. This diadochokinase is in the hand as well. This chart, if you want, we can provide to you, or you will get. But our suggestion for each and every station, for the 1 and 3, whether to say, that you start the examination of the patient from the foot end first, so that the right side, left side, top to bottom, head up to toe is visible, and very brief, few seconds, stay there, look at if any gross abnormality, any lateralizing features are there or not. It will be very, very useful. Even if you look at the eyes here, you can identify there is an nystagmus, facial deviation, everything in the wasting of muscles. In general look, most of the diagnosis be evident from the very beginning also. So with this foot end observation, then you tell the patient for the gaits that can you walk for me, and different types of gait give you an idea actually where is the wrong, what is underlying. More likely it could be upper motor or lower motor. The hemiplegic gait you found in the cerebral hemisphere lesion. And usually at the end of the nervous system, whatever the area we examine, suppose if we examine the lower limb, we need to complete our neurological examination by upper limb examination, cranial nerve examination, observation or palpation, the spine, neck, and sometimes we need to go for the autonomic neuropathy evaluation also. So if you finish upper limb examination, you need to include the lower limb cranial nerve and others, but in the exam hall, you are not given more time, but as a part of examination, the style of the examination needs that we are to say to the examiner, I like to complete my examination by doing this thing. And including other means, suppose if you found that patient having diabetic neuropathy, you can see that I like to dip the urine to see urine sugar. You can include in this manner also. For that, many things relevant could be there. But as a basic rule, that all the parts of the nervous system should be explored or examined. Okay. And why it should be examined, you will come to know now. Suppose if we go for motor pathway with this, the brain is controlling up to the muscle. So you now understand that the lesion may be from muscle up to the brain cortex anywhere. How to identify now? Suppose, assume that the person's having the weakness in the right lower limb muscles. Right lower limb muscles, maybe flaccid or the spastic. Now I will try to tell you that a rule of 2, if the muscle weakness is there, if it is associated with the problem of the basal ganglia issue, then we can tell that the lesion is the basal ganglia. For that, I'm showing you now an animated presentation to you. First of all, the limb weakness is here, muscle weakness is here in the right side, suppose in the leg, and the patient having the problem of cortex. So what are the cortical problems? So you see the abnormal mental status is the cortical problem, cerebral cortex, and it produces unilateral weakness, right-sided weakness. So other cognitive problems, seizures, these are the functions of the cerebral cortex. So any abnormality in the cerebral cortex is associated with the limb weakness, more likely lesion in the cerebrum. Okay, now come down. And you know that this is the basal ganglia. So our problem is the right lower limb. If it is the lesion in the basal ganglia, so associated features could be like that, you know, the functions of the basal ganglia and the features of dysfunction of basal ganglia, degeneration of the basal ganglia. So movement problem mainly, incoordination, diffuse incoordination, tremor, and the chorea. So now come down in another part, cerebellum. So usually in the cerebellar lesion, though we are discussing the limb weakness, in the cerebellum lesion, there is no weakness, rather incoordination. No weakness, no wasting also, that incoordinated movement actually resulted due to the cerebellar lesion, including the hypotonia. Okay, and the problem, you know, in the ipsilateral issue is there. Okay. Now another part, very important, the brainstem. This is, you know, the brainstem. And what are the associated features? If we find the weakness in the right lower limb, if it is associated with the cross paralysis, that means the opposite side of the cranial nerve are affected. So this is in the brainstem lesion. So which part of the brainstem is affected? Is the upper part, middle part, lower part? We will try our best a little later with you. But grossly, the cross paralysis indicates that the lesion is in the brainstem. And this message is very, very important for imaging modality to be selected also. I think you know that if cerebral cortex is affected, a CT scan may be of useful. But if the lesion in the brainstem or in the cerebellum, the investigation, that means the imaging of choice will be the MRI. So if you don't understand, if we don't understand that the lesion in the brainstem, simply we think that it may be the stroke due to cerebral cortex, and we advise CT scan, our imaging, the investigation will not be useful too much. Anyway, so this is a very, very important area of the brainstem. And again, I'm going to show you another area of the involvement. This is the spinal cord. So in the limb weakness in the right side, suppose, so spinal cord, as spinal cord is affected with the limb weakness, there are some other associated problems. Very important is the sphincter dysfunction and the definitive sensory level. The transaction of the spinal cord may be partial. In that cases, the sensory level may be unilateral, and the total damage of the spinal cord, we may get the sensory level bilateral. That means definitive sensory level in the right and left side. By the dermatomal distribution, you can identify. And there are other associated features also. But the more highlighted important feature of the spinal cord disease is definitive sensory level and the sphincter dysfunction. Okay. So I will highlight also a little more about the spinal cord damage a little more later. But let me finish up to the terminal part, that means the muscle. So now you can see that if the lesion is here, it is outside of the spinal cord. And what is this? This is spinal roots. And the muscle is weak. So the weak muscle is associated with the radiating limb pain. Definitely, reflexes are lost, like a lower motor lesion type. So this is the spinal root lesion in the same site. Now the distal more part of this pathway, this is the lower motor neuron now here, and this area is peripheral nerve. So if the peripheral nerve is affected, very easily you can understand that the reflexes are lost, and sometimes stalking or globe distribution of the sensory loss will be there. Mid or distal limb pain may be there, but usually, very commonly, we are following the rule of the loss of reflexes are there for identifying the peripheral nerve lesion. And now, more distal here, you know, this is the neuromuscular junction. And the weakness of the neuromuscular junction most likely of fluctuation. The days go on, and you know, the myasthenia gravis or Eaton-Lambert syndrome, the weakness is fluctuating by time. And there are no loss of sensation, sparing of the sensation, like the motor neuron disease as well. So this is the one of the area where the sensory problem will not be there. So you know the example of the disease. And finally, if you come to the muscle damage, it is also produce the muscle weakness. And these are the myopathies. And usually muscle diseases are bilateral, maybe proximal or distal. And here also no sensory abnormality is there. So this is the very gross differences is there, that in the muscle disease, initially there is no neurologic finding other than weakness. But in chronic cases, you may find the loss or weak reflexes and the wasted muscle also chronic. So I tried my best now, my beloved colleagues, that the weakness evaluation and with other features, how it can help us to identify where is the lesion. Anyway, I think the things are simpler to you. If you make a summary of these, that's where is the lesion. This is the picture. If you need, you can make a snapshot here. I tried my best to highlight here by the red mark, doctor. And in summary, very simply, in general look in our practice also, suppose patient is lying on the bed. If patient having the lower limb problem, if we instruct the patient, Mr. John, can you elevate your legs? Mr. John, elevate the leg with strength. So we can tell that there is no gross neurologic problem in the lower limb. If we say, can you elevate your both hands up? Patient can easily elevate both hands up, upper limb up. So we can say that grossly there is no neurologic problem in the upper limb. If we look at the face, there is no deviation and can tell the patient, Mr. John, can you move your eyes right and left? You observed that there is no problem of the movement of the eye or eyeball. So you can think that there is no cranial nerve problem. As you are telling the patient, you are instructing the patient what to be done and patient is doing. So there is no cerebral dysfunction. So in this summary, that by asking, elevating the lower limb, upper limb, moving the eyeballs, and by your observation, within few seconds, a gross observation can happen, can be done by you to say that patient does not have neurologic problem. But if patient have the complaint symptom, in that case, we need to be more minute, more minute. So if you say that, just look at just two words here, the cerebral problem is there with the limb weakness. So weakness affecting the head, the head part. Head part means the including the cranial nerves and others, including the limbs. But if we think that the lesion is the spinal cord, or we found that the weakness in the limbs only, upper limb or lower limb, suppose if the cervical spinal cord is affected, maybe upper limb, lower limb, both together affected, but no cranial nerve problem, no higher cerebral dysfunction. So lesion is in the spinal cord. In that manner, actually, we need to develop our IQ, our understanding to evaluate neurologic cases. So it is usually a time, what I say, the more time related topic. If you want to know, you need to pay more attention and make a calculation like a mathematics rather to say where is the lesion. So within my the short talk, I tried my best to make the things are easier. And if any time we get chance to give you idea also for better understanding later. But for the exam, we designed the planner for lower limb examination and its diagnosis. I think if you can keep this picture in front of you, will be of more use. Usually, patient will be of paraplegia, and we divide into the upper motor neuron lesion and the lower motor neuron lesion. If it is the upper motor neuron lesion, more likely diagnosis could be this, and the lower motor more likely to be this. I think if you can preserve the picture, you can now can do the permutation combination including the cerebellar signs, what could be the underlying diagnosis? These are the observations found in the last many years, really, in the Royal College exam. These are the underlying diagnoses. And we will actually discuss about the cord compression a little more, I told you. So these, the below box showing the cerebellar syndrome. And the cerebellum is involved in many diseases. It may be only cerebellar lesion, or cerebellum may be associated with the lesions in the other part of the nervous system. So first identify the cerebellar lesion, then go for the underlying diseases, maybe the multiple sclerosis. There are some additional features. I don't like to read all of the things, and most of you know it. Make a snapshot. I think it will be easier for you. And again, the right box is how to complete the examination. More relevant. If you examine the lower limb, then add other thing, upper limb and other part of the nervous system I like to examine. Similarly, DOAMS created another planner for the upper limb examination. If patient presented with the monoplegia, then you can divide the lower motor findings with this differential, the upper motor finding with this differential. So the cerebrovascular disease is very common, as well as the Pancoast tumor. Pancoast tumor. I can remember now my case also before in my exam. The Pancoast, sometimes difficult, patient might have the severe pain also. Anyway, maybe the post-surgical cases will be there. The lung lobe removed, underlying cancer was there maybe, and patient have the permanent neurologic damage. So it could be the Pancoast tumor. So similarly, if you come to the diplegia of the patient in the upper limb, so maybe underlying with this permutation combination, we tried our best with the color combination for a better understanding. One thing you understand that the multiple sclerosis everywhere, the monoplegia and the diplegia. So multiple sclerosis, the disease is as such, and it is said by the neurologist also that if you cannot make a calculation in the neurologic examination finding, and all the findings like to the upper motor neuron lesion, until proved otherwise, it will be case of multiple sclerosis. So multiple sclerosis could be a diagnosis of exclusion also. For that, we mark by the star here that upper motor neuron also could be multiple sclerosis, and the always is upper motor neuron, but monoplegia and the diplegia can be presented with underlying diagnosis of the multiple sclerosis. Now, if a patient presented with the tremor in the hand, more likely the Parkinsonism or Parkinson's disease, and to differentiate from the essential tremor, and patient may have the dystonia, and without wasting, usually it will be a cerebellar disease. In the lower part, you understand, doctor, the syringomyelia, the box actually will give you the idea. I don't like to read more here. And we described it before, the cerebellar syndrome also. You are instructed to examine the upper limb, but underlying there is a cerebellar syndrome, that finger nose test and these diadochokinesis and other. So these checklists, we believe that be helpful for you. And I think we don't need to break now, as you didn't raise the hand, we need to proceed further. Okay, a few things more waiting for you. Maybe don't worry, we will try our best to finish early. And a little more information for your brainstem disorder, doctor. Again, to show you the picture, the surface attachment with the cranial nerves of the brainstem. And what are the brainstem syndrome rather? And it's very common, including the third nerve palsy and the diagnosis of Weber syndrome. So if third nerve palsy is there, maybe that third nerve nucleus are involved, and the lesion in the brainstem, superior colliculi, inferior colliculi level there, especially superior colliculi level is of third nerve nucleus are there. So if the ipsilateral third nerve, then it will be the Weber syndrome. And I think you understand that in this Weber syndrome, brainstem syndrome, patient will have the limb features also. Remember, we discussed before, if the lesion in the upper level, the patient suffer from the lower level also in the target tissue, especially the muscle, we like to say. Similarly, if it is the ipsilateral third nerve palsy, the cerebral peduncle is affected, including the red nucleus. It could be the clot, but just for practical purpose, the Weber syndrome is very common in the PACES exam. Similarly, one very important syndrome is Wallenberg syndrome or lateral medullary syndrome. Very interesting, the lateral medulla, I think all of you know, but today's discussion may be helpful for you. Again, if you give a clinical picture to you, and you know that you are already looking that the highlighted areas are there in the red and the blue. Even then I am reading for all of you because I think you are taking more time to decide to read or not. Anyway, a 63-year-old male admitted with acute onset unsteadiness of gait. So unsteadiness means that ataxia, and you may think that it may be sensory ataxia or the cerebellar ataxia. Patient have the dizziness as well as the dysphagia also. Examination revealed a left-sided Horner's syndrome and the nystagmus. And whenever you found the nystagmus, it may be originated from the cerebellar disease or the vestibular disease. Loss of pain temperature on the right side of the trunk and in the right arm and the leg, there is a gait ataxia. So this unsteadiness of the gait actually was the gait ataxia. So altogether, there are some motor problem as well as sensory problem. The most likely artery is involved is posterior inferior cerebellar artery. And this is the picture now to you. When the posterior inferior cerebellar artery is involved, this is the blue area marked here, doctor, for that is the lateral medullary syndrome. Another word is the medial medullary syndrome, but more likely in the last few years also, these were the common case. And it is found. So these are the clinical pictures. If you can try to remember, it will be better for you to identify the, the lateral medullary syndrome. Okay. So it is another name, the Wallenberg syndrome, pica, pica. And including, you see why the sympathetic Horner syndrome is there. There is a sympathetic tract also there in this part. Anyway. Now a few words about the spinal cord syndrome. And the most common topic in the MRCP PACES neurology station in the lower limb is spinal cord syndrome. Very simply, when you found that the case of the paraplegia or paraparesis, it may be upper motor neuron type or it may be lower motor neuron type. But interesting thing is that in the initial days, patient may suffer from the shock. It is called the spinal shock. If in the spinal shock, patient will show the flaccid type of the paraplegia or paraparesis, though it is upper motor neuron lesion. So try to remember this thing. And if it is the upper motor type, so now where is the lesion? What we discussed before. Now we can correlate. If it is in the cortical lesion or the spinal cord lesion. If it is the cortical lesion, there may be, you see, if we are discussing now the paraplegia, doctor, not the hemiplegia. So patient will have the lesion in the cerebrum, by the anatomy. It is the superior sagittal sinus area if there is a thrombosis or any tumor involving the falx cerebri. It will compress the motor and sensory area in the brain, from the anatomy. So it can cause only the paraplegia, sparing the upper limb, because the homunculus, the topmost area of the brain, is actually concerned for the lower limb. Otherwise, the spinal cord lesion is the common cause of this paraplegic patient. And we need to understand the spinal cord is the compressive myelopathy or for the non-compressive myelopathy. Very easily, compressive myelopathy means the compression by the tumor or the disc also or the damaged bone. So now come to talk on little of compressive and the non-compressive spinal cord disease. These are the, in general, simplified causes of compressive and the non-compressive myelopathy. Compressive is due to the tumor, abscess, herniated disc, or vertebral damage. In the non-compressive is the vascular, inflammatory, or infectious disease. How to differentiate? A little clue could be helpful for you that it is a compressive or non-compressive myelopathy by examination or evaluation of the symptoms and signs of the lower limb issue by neurologic examination. For better understanding, if you can look at the picture, if you find that in the sensory pathway, the tracks going up, if from outside any compression happen, if you look at the blue color here, these are the sensory tracts and they are the motor tracts. In the evaluation of the symptom, so usually in the station, clinical examination station may not be evident because we are not allowed to talk to the patient. But if you find only the sensory problem very incidentally, initially it is due to spinal cord compression. The motor function may be spared. But in real life, uncommon situation will happen that patient presented only with the sensory problem. So we get the patient of the paraplegia with the motor problem. Just for better understanding, I like to comment here that if we come to know the evolution, that patient initially have the sensory problem and few days later, after a while, patient develop the motor symptom. And patient is now presented with a paraplegia. So we can think that it is due to the compression of the spinal cord. So compression means compression from outside, And autonomic fibers stays in the center of the spinal cord. So the autonomic dysfunction happened very lately in the spinal cord disease. Means if a patient presented with the paralysis as well as the bowel bladder issue, almost the whole spinal cord is involved and the center part of the spinal cord is involved. For that, we have shown before, if the sphincteric dysfunction is there, more likely it is due to the spinal cord syndrome. So this picture will be useful for you for better understanding now. The compressive and non-compressive myelopathy. And you know that by knowing the dermatom, we will identify the definitive sensory level. Just to refresh your memory from the lower limb. And these are in the upper limb, including the chest. You know, in the thoracic 10 is the umbilicus and external area is the thoracic 7. So we can distribute now. And there is a junction of the C4 and T2s. You see the thoracic 2 and the cervical 4. There is a junction and the remaining actually spread out by projection by the limb bud during the embryogenesis. So these are distributed along the C4, 5 like this, 6, 7, cervical 8, and then from here if you count that the 5, and the 6, the 7, 8, and then come to up T1 and T2. Now come to the T2 here and down. So just for actually memory, I have shown and again the upper limb area. And we need to be very fluent. If you become hesitant in the examination, actually it will underscore you in the exam. For that, try to keep the picture in your memory. The dermatoma will be useful. Now coming to a little critical area for understanding and our attitude to talk to make the topic easier for you now. Please be with me a few minutes more. And this is the lower part of the spine. You see the sacral area, there's the lumbar area here. The spinal cord is finished at the lower border of the first lumbar vertebra, you know, almost here. So from these and up above, the roots are coming down and coming out along the intervertebral foramen. So spinal cord is finished. So the lower part, you know, the chorda equina is coming down. So if any lesion, any transaction damage happening here, it will involve only the chorda equina, not the spinal cord. So chorda equina means lower motor neuron lesion. By searching more, actually which spinal segments are corresponding with the damage by term called equina lesion or the conus medullaris was actually confusing to me. And searching many books, I come to know up to this message. If any of colleagues have very specific information, you can share with us and helpful for everybody. Anyway, it's from the Harrison's medicine, that the author described that the conus medullaris, the terminal part of the spinal cord, actually contain the lower sacral and single coccygeal segments here. But cauda equina contain the roots of lumbosacral areas because, there is a coming from up. So lumbosacral area going down one by one and coming out by the intervertebral foramina. But this cauda equina represent the lower motor neuron and the conus medullaris as a part of the spinal cord. It represents the upper motor neuron. But in the evaluation process, we will find that the conus medullaris syndrome presents with the mixed upper and lower motor neuron signs. Because you found that any disease process involving, suppose a tumor compressing the conus medullaris, but it will compress some fibers of the cauda equina also. So in the clinical practice, we find the conus medullaris syndrome with mixed upper and lower motor signs. And another explanation also I will show you that why in the lower limb examination, in the jars, we find as upper motor or lower motor type. And the cauda equina, just lower motor sign. Now, come to this table comparing the conus medullaris and the cauda equina syndrome. Suppose the reflexes, as we said, I'm going back, doctor. The conus medullaris contain the lower sacral and the single coccygeal. Try to remember, doctor, this word, lower sacral and single coccygeal. So if another author can include some sacral above lower sacral, maybe sacral 1, 2, 3, but we can confidently say that the conus medullaris does not contain the spinal segment of the lumbar spinal nerves. Lumbar spinal nerves, okay. Keeping this in mind, if you come here, if we analyze the reflex findings by the knee jerks and the ankle jerks. So if you find the conus medullaris syndrome, knee jerks will be preserved, ankle jerk will be affected. Affected means there may be abnormal response of the jerks. Okay, but knee jerks is preserved. But in the cauda equina, both knee jerks and the ankle jerks are affected because this is just lower motor neuron features. So lower motor means both knee and ankle jerks are absent. But here, knee jerks is preserved. Intentionally, actually, I highlighted here because when we go through our book of medicine, I think all of you know that from which book we have collected it. In the differentiating point, the conus medullaris and the cauda equina, just follow these two columns. In the reflex part, they are telling that the knee reflex is increased. But logical understanding telling that knee reflex will be preserved. That is the difference, doctor. And actually, I don't like to say that the book is telling something wrong, rather maybe this is their analysis, their explanation. But for better understanding with the logic, anatomy, thing will be that in the conus medullaris, knee jerk will be preserved. But ankle jerk will be decreased and the plantar will be extensor as upper motor neuron features. Now the cauda equina, we agree with that. The flaccid paralysis, just like lower motor neuron sign. And commonly the conus medullaris or cauda equina patient presented with the saddle anesthesia. After this, doctor, I like to share some mnemonics we actually created for better understanding by collection from other books. The findings when we examine the lower limb, with some time we find that A0P1 means absent ankle plantar extensor. So plantar extensor is the features of upper motor features, but absent ankle is features of the lower motor neuron feature. So now again mixed up. What may be the cause if we found it? So we are considering now the ankle jabs and the plantar, but there may be associated the absent ankle or maybe there. Anyway, if commonly we found earlier, the earlier features will be the A0P1. P1 means up, easy to remember. So combination of the disease is the most common cause, combination. Suppose patient suffering from peripheral neuropathy as well as cervical myelopathy. So for the cervical myelopathy, patient will produce upper motor neuron sign. This is the plantar extensor. For the peripheral neuropathy involving the peripheral nerve, ankle jab shows absence. Like this. If we make a combination peripheral neuropathy with the stroke, it can produce this A0P1. Or the cervical and the lumbar disc disease can cause this thing. Another one is conus medullaris, just we discussed before, the mix up of upper motor and the lower motor features, A0P1. So there are some C, Dr. C, combination, conus, as well as the common C. Another causes of this thing, the popular mnemonic is the MAST, M-A-S-T. So motor neuron disease, Friedreich's ataxia, subacute combined degeneration of the cord, including the copper deficiency and the Tevis dorsalis. So this chart also will be helpful, doctor. You can, if you feel that it will be useful, you can make a snapshot. No restriction. I think that you are not tired, and with few minutes we can go to the end. The later part of cranial nerve examination. Actually, I feel to stop here, but as you didn't raise the hand, so I am going forward. So these are the checklist. As before, we have shown to you for the upper limb and lower limb. This is the cranial nerve to make easy cranial nerve examination. You will go through by yourself, doctor. Just highlighted areas of endoscopy is a part of cranial nerve examination. And if you minutely see that, is a tradition that is called tradition. And we need to be used to of our tradition of the PACES exam. Suppose we are asking one question, but we are telling that we are examining the cranial nerve. It may be controversial, right? Examination is examination, not the history taking. But this is adopted in the clinical examination technique. What is this? Have you noticed any difficulty with your sense of smell at this examination of the cranial nerve 1? Have you noticed any difficulty with your sense of taste? This is the 7th cranial nerve sensory part. So this is a tradition, we need to adopt it. Okay. Then another eye examination is very important. Fundoscopy, and I think if you are attached with us from many days before, you can see the fundoscopy discussion in the YouTube, also doctor, and the later part also I like to give you our link so that you can see. And if needed in future, an updated fundoscopy topic will be taken. But up to this, today we are not discussing detail about the eye examination and the fundoscopy. Anyway, if you come down, finally, the 12th cranial nerve also in this manner. And I assure you that as much as possible, it is our customized the cranial nerve examination panel shown to you. It is not as it is from anything, but is a collection of many sources. This is our customized cranial nerve examination planner. I hope that it will be useful for you. Planner means the methods. Now, with the cranial nerve examination, if I show you the picture of this lady by looking the face, can anybody say that what is wrong with her? Maybe a snap diagnosis primarily. Can anybody say, please? Can anyone? Please, yeah, Dr. Azad, please.
Sir, it seems like patient have right-sided partial ptosis.
Very right.
Or, sir, another possibility, but I should not say that in the exam settings. It could be, sir, left eye prosthesis or something, because the both eyes are not looking the same.
I'm telling the symptom. Patient does not have vision problem in the left eye, so it is not prosthesis. But
Okay,
but the neurologic finding, you said very nicely. Now another doctor raised the hand. Sorry, doctor, I cannot address with your name. Yeah, can you introduce by yourself by name, doctor?
Okay, Dr. Abu Bakr, this is the left
Welcome.
7 cranial nerve.
7th cranial ablation, you mean?
Also, yes.
Okay, so we like to hear from third doctor, anyone to find. So now the opinion differs. So we need to make a medical board, multidisciplinary team also. So can anyone say more in the face? No more? So now I have to give the ruling. So if you look at, doctor, that this partial ptosis, there is no confusion. And I said that this is a normal appearance of the eye. And if you compare the frontal muscles there, the right frontal muscle is more active. Yeah, doctor, who raised the hand now? Dr. Bakar, possibly. Sorry, your name is not here. Can you be connected with me? I'm sorry to say that your answer is wrong for that. Can you be connected with me, doctor? Sorry. You have given the mic, doctor, who talk to me now. Better for you. So if the muscle is active more, means actually patient trying to overcome this vision problem by this ptosis. For that muscle is in action. So more likely to be a Horner syndrome here. But still we are not sure this is Horner syndrome or not. As I know the patient, I know that this is actually, we said that familial Horner or congenital Horner sometime, but is without any clinical significance. Patient does not have anything. Sorry, not congenital Horners or other, rather to say the partial ptosis is only partial ptosis. There's no other pupillary findings and others thing. For that, patient using the forehead muscles. So this is a unilateral issue. Actually, I like to highlight more here with this picture, the subsequent one. Please, doctor, can anybody say here, there are also partial ptosis? What may be the underlying cause of partial ptosis? Anyone? If Dr. Azad feels better, you can tell also.
myotonic dystrophy, sir. This is a typical face. Long, haggard face, balded forehead.
So
and
it is helpful features to say myotonia dystrophica. But if we come and if we only focus this area, in the ptosis area, how can we explain that it is not Horner syndrome?
Sir, as you mentioned, the overactiveness of the forehead muscles is not present here.
So this the myopathy is there.
Yes, sir.
Myopathy is there. So this is the logic. Thank you, Dr. Azad. Very rightly you're
Yes.
telling. So usually myopathy is bilateral disease, and there's a bilateral partial ptosis. Other thing is associated for the myotonia dystrophica. It will be useful and helpful for us. But if you compare, and we learn that this partial ptosis is due to the nerve-related problem or the muscle-related problem. Just look at the forehead. The bilateral muscle is inactive, so it's a myopathy, and the associated with other features. Confidently, clinically, we can tell that this is a case of myotonia dystrophica. Thank you, Dr. All of you who participated. So again, the thing after examining the cranial nerves and others, we like to say, I like to complete my examination by examining that relevant, the upper limb, lower limb, spine, especially for the cranial nerve, maybe neck may be needed to be examined, but not the spine down. Anyway, if you want, you can add also the autonomic examination, autonomic disturbance. Right. So this is again other chart, the cranial nerve lesions. These are the features. And to make convenient and easy understanding, we are sharing some pictures that actually this is the cavernous sinus to refresh your anatomy. And whenever the cavernous sinus lesion is there, including these cranial nerve features will be there. And if it is the orbital apex, this is the orbital apex, and the cranial nerves related are there. The jugular foramen is there. So the 9th, 10th, and 11th cranial nerves will be affected here. And the CP angle tumor is very common tumor, acoustic neuroma. And you know, the picture now, the acoustic nerve is here, 8th cranial nerve, there is a tumor. So it is near the pons and medulla junction, and the whole anatomy of the brain we can remember. This is at the cerebellopontine angle, most common tumor of the brain, usually to be said. So these are combination we need to remember after cranial nerve examination. And these are the DOAMS planner for the cranial nerve examination. And your diagnosis will be like that, commonly found. The 3rd nerve, 6th nerve, 7th nerve palsy, multiple cranial nerve palsy we have shown before. Lateral medullary syndrome also will come up from this. And the nystagmus usually give a clue of cerebellar syndrome. Nystagmus, more likely underlying diagnosis was multiple sclerosis. And there are some fundoscopic cases. Yeah. And the cerebellum already we discussed before. The cerebellar syndrome also could be diagnosed by examining the cranial nerves, by looking at the nystagmus. So this is the cranial nerve topic ended. And now few things on the miscellaneous examination, maybe 5-10 minutes may be needed more at best, so that we can finish today's topic. In general, the cerebellar lesion, the instruction of Royal College is as such. That means the patient having incoordination, examine the patient. Or look at the patient and proceed further like that. Or when you examine the lower limb, you found that when you have the problem of the gait and there is incoordinated gait, then you can identify that there is cerebellar ataxia or underlying disease in the cerebellum. It could be in any of the cerebellar syndrome. So cerebellar diagnosis could come out from upper limb examination, cranial nerve examination, lower limb examination. Any channel may be used. Now, a quiz a little for you, anyone. Please, if instruction is as such, look at the patient and examine as appropriate what you are thinking now by looking at the patient. These are some miscellaneous type of instruction used in the MRCP PACES exam. Can anyone say, better to raise the hand, doctor? Look at the face. Though the picture is not bright, clear, even then you identify a senior gentleman looking to you now. Yeah, doctor, please. Dr. D in short, eh? Don't mind as you have read. Yeah.
Yes, this patient looks like having alcoholic liver disease. The abdomen is distended, somewhat gynecomastia, and I think, yes.
But there is no other features of chronic liver disease. You think that the gynecomastia may be a physiologic response in elderly patient also, like the adolescent. Adolescent. Usually in the neurology station, we need to be tricky. Okay, doctor? Who are talking with me, be with me. We need to be tricky. Tricky means we are now discussing about the neurology cases, not the abdominal case. Okay? So forget the alcohol-related liver disease. Come to a neurology case, patient is looking to you with very, very expressionless face. So what could be the underlying cause now?
Parkinson's disease.
Very rightly. So now, what to be done next are the features of the Parkinsonism could be identified. So these are the simple miscellaneous type of instruction described here. More likely diagnosis could be Parkinson's disease. Elderly, right? Geriatric cases, Parkinson's disease.
Right.
Yeah, thank you, doctor. Now another one. I think we discussed before. Already Dr. Azad nicely explained, so no need to discuss first. Look at the patient and examine as appropriate. So now, what else you will like to examine now? If I ask in that manner, who can give the answer? You are looking the face, your underlying diagnosis could be myotonia dystrophica. Now proceed further. What you will examine now? Few examination findings. Can anybody add here? No one?
Yes, sir.
You know. Yeah, Dr. Azad, please give the chance. Other colleague, he raised the hand. Yeah, doctor. What else, doctor? You are Dr. Bakar, maybe? Sorry, doctor. Sorry. Again, you muted, doctor. Unmute, please, first. Maybe your system is not helping you. First, yeah, now it's okay. Please. What you will do now?
Okay.
What you will examine further of this patient?
Okay, this patient, yes, I must differentiate. This is not myasthenia gravis. Okay, I will examine the face.
What
The
else,
muscle of
doctor?
the face.
You are looking by inspection, some findings are there. So in closer look, what you will try to explore further in this patient in favor of diagnosis of myotonia dystrophica?
First things, yes, I will examine the muscle of the face.
Okay, strength and other you can identify then.
Okay, I will examine the muscle of the neck.
Okay, then.
Then I will examine the upper limb.
Okay, upper limb for what?
For hypotonia, for distal weakness,
Muscle weakness,
and for
but
myotonic.
there is a dystonia is there in the muscle, right? Hand grip dystonia, percussion dystonia, maybe there.
Percussion dystonia.
Okay.
Then, then I will check for the heart.
Yes, doctor. Why you will check for the heart?
Cardiomyopathy.
But how will you get the findings of cardiomyopathy? Very simply.
I will check the apex. Then I will auscultate.
Auscultate. Can pulse give you idea of cardiomyopathy? Simply pulse.
Yes.
How?
Either in there is tachycardia or pulses alternates.
Rather to say arrhythmia.
Yes.
Arrhythmia, very simple. Thank you, doctor, for your better understanding. Very nicely you are telling. So, the neurology, when it is said that you are attending a neurology cases, okay, look at the patient and examine. So, it is not neurology per se, it is a myology rather, myopathic case. So, instruction found in the neurology cases usually, or it may be the case in station 5 also, whatever, wherever it is, examine as appropriate. So, you can check the pulse also. You can check the pulse also. And you find that this, why there is a clue, you know, that the skeletal muscle have some similarities of the cardiac muscles. All are the striated muscles. But the skeletal muscle is voluntary, cardiac muscle is involuntary. So there are some similarities. So muscle degeneration or muscle damage happening in the skeletal muscle in the same process happening in the cardiac muscle also. So there is associated cardiomyopathy and patient may develop the arrhythmia. Anyway, the myotonia dystrophica rather to be understood as a syndrome, not only the muscle disease. Patient might have endocrine problem also. Doctor, the last question to you, what endocrine problem you try to exclude here? Who answered before? You can answer again. Be unmuted, please, first. Yeah, doctor. Sorry, you are taking time. Dr. Azad, please. What endocrine disease we like to exclude?
For the diabetes mellitus,
Very
and should
fantastic.
be deep urine stick test, sir.
Right, right. So by this understanding, your examination will be finished. So I think we are in the last 1 minute, maybe. Here, look at doctor. The 5 top. So actually, we finished our discussion now up to the neurology, the different topics and the highlighted topics. I hope that it will be, this discussion will be very helpful for you. Now, the remaining thing is for your practice according to the cases. You may practice in online session. It's better practice to be done in the bedside. But before going to the bedside, actually, we need to be ready by mocking earlier or a virtual class you have to create by yourself with your partner by giving the findings and others. And it is very useful. For the exam purpose, for the preparation, we like to highlight you now, doctor, to say that it is found in the top listed cases in the neurology. The peripheral neuropathy underlying cause was diabetes, hereditary sensory motor neuropathy, and the CIDP, cerebellar syndrome, Parkinson's disease, old stroke patient, and the spinal cord disease. And the spinal cord disease may be compressive or non-compressive. These are top 5, but there are some other cases also. I will show you again. maybe the MND, motor neuron disease, and other myopathies, including myotonia dystrophica. And these are the broader list for you, doctor. You can see now. In the meantime, I will show you our. You can see now, doctor. 1 minute. The lower limb presentation, mainly underlying diagnosis as such and as such. You can follow. In the meantime, I like to share our links also so that you can join with us in our regular discussion in the chat box. If you want to join, still you didn't join, you can join our WhatsApp as well as the Telegram. And most of you know that every Friday we are trying our best many months before in a free session so that you can get the messages earlier, and many important posts are there. Small clues are there, right? You can join by one click now in the chat box, or you can copy for future. Anyway, what we like to say, these are the detailed list in the neurology. Top 5 cases we have shown before. Now, a little more cases. These are the common regarding this. When you examine the lower limb, almost you will get cases from here. Regarding examination of the upper limb from here, cranial nerve from here, and cerebral presentation means Parkinson's disease, Huntington, and the hemiparesis and the expressive dysphagia. Usually less common, only the dysphagia. But as a mature doctor, as we are going to be specialists in the medicine, we must know it. The final message is, remember that the MRC scheme mainly, in the neurology especially, mainly rewards good examination rather than spotting the diagnosis. A special message for neurological examination. So your planning of the examination, method of examination is the important thing to be considered by the examiner in the neurologic examination. And you can make your examination plan by in this time frame. This is our suggestion. You can modify by yourself in all of the station 1 and 3 any cases, not only neurology. In the 5-minute general observation examination, we divide in the examination proper. So general means, I told you, pulse, blood pressure, anemia, jaundice. These are the general part, and the proper area of instruction, maybe the chest, heart, or the lower limb, upper limb, like that. Examination proper. And last 1 minute, after the 5-minute, 1 minute for the wrapping of examination. Right, wrapping means when you have heard that the 1 minute left, in the last 1 minute, some important things you missed, you finish it and try to make a consolidated diagnosis as a clinical diagnosis. And the last 4 minute, examiner will ask you these questions, common questions as such. So I'm not reading out for you. And these are our YouTube links, doctor. Already, I think you can get in the group, WhatsApp or the Telegram, our common YouTube link. So you will get many discussion from the pages, including all stations, basic things as well. Thank you very much for your patience of long time with me.